The neutral foot can present with pathologies relating to daily activities, sports or exercise, and occupational demands. From the posterior view, this foot may present with the calcaneus vertical, or very mildly inverted or everted in the frontal plane, with even malleolar curves and the toes equally visible on the medial and lateral sides. From the medial view, this foot will present with a normal medial longitudinal arch height, with equal talar head palpation both medially and laterally. From the medial oblique view, the talar navicular region does not present with a bulge or is hollow. Using plantar pressure analysis, this foot will present with a normal pressure pattern with no focal high points or abnormal pressure areas. The neutral foot will present with normal patterns of proximal function at the ankle, knee, and hip in the frontal, sagittal, and transverse planes. It will display an optimal pattern of high gear toe-off through the first MPJ, with good windlass function of high range, low force, and immediate activation. The forefoot will be stable during propulsion. The neutral foot will also present with a relatively normal or only mild variations to the expected gait timing events from heel strike and foot loading through mid-stance and into propulsion and toe-off. Despite relatively normal foot function, your patient may still present with pathologies relating to their lifestyle or other factors. Your patient may present with pathologies relating to the demands of daily activity, sport and exercise, or their occupation, pushing tissues beyond their functional capacity while still displaying normal or only mild variants of foot function. Poor footwear choice, low tissue capacity, previous injury, age-related changes, or an underlying disease process may all link to the pathological presentations, including forefoot pathologies, general forefoot pain or metatarsalgia, neuroma symptoms, or metatarsal capsulitis, bursitis, or neuritis. Midfoot pathologies, including plantar fascia or medial arch strain, mid-tarsal joint or Lisfranc injuries, or midfoot osteoarthritis. Rearfoot pathologies, including plantar fasciitis, plantar heel pain, or fat pad syndrome. And lower limb or ankle pathologies, including Achilles tendinopathy, gastroc or soleus pathology, or lateral ankle instability. Or leg, knee, hip, and back pathologies, including those affecting the patella or patellofemoral joint, the meniscus, sacroiliac joint, or the lower back. For daily education and training, follow us on social media, including Facebook and Instagram. Subscribe to our YouTube channel, follow us on LinkedIn, or visit DOLAOrthotics.com. The pronated foot is a common presentation associated with many tissue stress pathologies of the foot and lower limb. From the posterior view, this foot may present with the calcaneus trending from a vertical to an everted position in the frontal plane, more concave malleolar curves, and the toes visible more laterally. From the medial view, the foot may present with a lower medial longitudinal arch, with the talar head palpable more medially than laterally. From the medial oblique view, the talar navicular region may appear more prominent, otherwise known as a talar navicular bulge. Using plantar pressure analysis, this foot may present with an increased plantar surface contact area and high focal or local pressures, often at the second metatarsal, metatarsals 2 to 4, or the medial and distal hallux. The foot may present with a primary ankle equinus, with proximal and distal compensations at the knee, hip, subtalar joint, and mid-tarsal joint. On assessment, there is a reduced non-weight-bearing ankle range of motion and reduced weight-bearing ankle function. A sagittal plane block at the ankle, or an ankle equinus, is a decreased ankle range of motion due to tightening of the posterior structures, including the gastrocnemius or soleus. The foot may present with pathomechanical function beyond its tissue capacity, including functioning at or near end range of motion of rear foot eversion from heel strike into midstance, or prolonged midstance pronation with lack of resupination into propulsion. This can lead to an impaired propulsion phase and poor windlass function. It can show signs of functional hallux limitus, including avoidance of high gear toe off with a lateral or low gear toe off, or proximal compensations. On functional examination of the windlass mechanism with the Jack's test, results may include a reduced range of motion compared to non-weight bearing, high force needed for activation, or a delay in initiation. Local and proximal compensation combinations may include abduction of the leg with medial toe roll-off on propulsion, or adduction of the leg with a lateral toe-off. Other common signs in gait may include forefoot instability, a prolonged midstance phase, and avoidance of the first MPJ high gear toe-off. On examination, the forefoot of the pronated foot can present with several features. They include an abducted forefoot, hallux limitus, a dorsiflex first ray, or functional hallux limitus. A pronated foot can also present with many mistimed gait events. They can include heel lift, the previously mentioned prolonged midstance phase, or low gear and lateral toe-off, and impaired propulsion and windlass mechanism. Your patient may present to your clinic with many pathologies relating to their foot posture and function, including various forefoot pathologies, including skin changes or hyperkeratosis, general metatarsalgia, metatarsal capsulitis, bursitis, neuritis, or neuroma, all relating to the impaired forefoot function in loading, but especially during propulsion or toe-off. First MPJ pathologies are also common, including bunions or HAV, and the development of hallux limitus and sesamoiditis. These are all related to the foot loading, functional hallux limitus, and forefoot instability. Toe deformities may also indicate impaired forefoot function, including plantar plate injury, claw toes, or retracted toes due to muscular imbalance. Common midfoot pathologies include plantar fascia or medial arch strain, sinus tarsi syndrome, mid-tarsal joint or Lisfranc injuries, cuboid syndrome, and midfoot osteoarthritis, all relating to the foot loading and increased tissue stress demands beyond tissue capacity. Common rear foot pathologies include plantar fasciitis or plantar heel pain, heel spur, tarsal tunnel syndrome, fat pad syndrome, retrocalcaneal bursitis or Haglund's deformities, all relating to the foot loading and increased tissue stress demands beyond the tissue capacity. Posterior or anterior lower limb and ankle pathologies include Achilles pathologies, soleus and gastroc pathologies, flexor hallucis longus pathology, and anterior ankle impingement or extensor tendinopathies, all relating to sagittal plane function, foot loading, and the increased tissue stress demands beyond the tissue capacity. Medial lower limb and ankle pathologies can include medial tibial stress syndrome, shin splints, and tibialis posterior pathologies, all relating to the frontal plane function, foot loading, and increased tissue stress demands beyond the tissue capacity. Common lateral limb and ankle pathologies include lateral ankle instability and peroneal pathologies, relating to the frontal plane function, foot loading and instability, and increased tissue stress demands beyond the tissue capacity. Due to the proximal chain compensations previously mentioned, the patient may also present with common pathologies affecting the patella, patellofemoral joint, the knee, the sacroiliac joint, or the lower back. For daily education and training, follow us on social media, including Facebook and Instagram. Subscribe to our YouTube channel, follow us on LinkedIn, or visit DOLAOrthotics.com. The supinated foot is a complex presentation, often displaying a combination of pathomechanical function in the frontal, sagittal, and transverse planes. From the posterior view, this foot may present with the calcaneus trending from a vertical to an inverted position in the frontal plane, more convex malleolar curves, and toes visible more medially. From the medial view, the foot may present with a higher medial longitudinal arch, with the talar head palpable more laterally than medially. From the medial oblique view, the talar navicular region may appear more concave or hollow. Using plantar pressure analysis, this foot may present with a reduced plantar surface contact area and high heel and forefoot pressures. During sagittal plane function in gait, due to the more rigid foot structure and the lack of rear foot eversion, the supinated foot may present with poor shock absorption, leading to compensation in the proximal chain at the ankle, knee, and hip. Another common presentation of this foot type is a sagittal plane block at the ankle or an ankle equinus, which is a decreased range of motion due to tightening of the posterior structures, including the gastrocnemius or soleus. During foot loading from heel strike to mid-stance, the foot may also present with lateral instability as seen by overactive perineals, prolonged loading of the lateral foot, and maintenance of a lateral toe-off pattern. The lateral toe-off pattern, or low gear toe-off pattern, is a sign of impaired propulsion and may also result in proximal compensations. On examination of the forefoot, the supinated foot can also present with several features. They include an adducted forefoot, a forefoot valgus, a plantarflex first metatarsal, or a forefoot equinus. A supinated foot can also present with many mistimed gait events. They can include the previously mentioned poor shock absorption, prolonged lateral loading, a low gear or lateral toe-off, and impaired propulsion and windlass mechanism. Your patient may present to your clinic with many pathologies relating to their foot posture and function, including various forefoot pathologies, including skin changes or hyperkeratosis, general metatarsalgia, metatarsal capsulitis, bursitis, neuritis, or neuroma, all relating to the high loading and high forefoot pressures and impaired forefoot function, especially during propulsion or toe-off. First MPJ pathologies are also common, including bunions or HAV, and the development of hallux limitus and sesamoiditis, all relating to forefoot loading, function, and instability. Toe deformities may also be a sign of impaired forefoot function, including plantar plate injury, claw toes, or retracted toes due to muscular imbalance. Arch and heel presentations are also common, including plantar heel pain, plantar fasciitis, Achilles pathologies, fat pad syndrome, and midfoot osteoarthritis, all relating to the foot loading and increased tissue stress demands. The lateral foot loading, lateral toe-off, and instability can all be related to presenting complaints including perineal pathologies, lateral foot pain, cuboid syndrome, and lateral ankle instability. Due to the proximal chain compensations previously mentioned and poor shock absorption, your patient may also present with common pathologies affecting the patella or patellofemoral joint, the knee joint, sacroiliac joint, and lower back. For daily education and training, follow us on social media, including Facebook and Instagram. Subscribe to our YouTube channel, follow us on LinkedIn, or visit DOLAOrthotics.com.